Good morning, everybody. Thank you for joining us for another APSAD Insight webinar. My name's Jim Hunt. I'm one of the nurse educators here at Insights. Before I begin, I'd like to acknowledge the traditional owners and custodians of the land on which I'm presenting on today. So for me, that's the Yuggera and Turrbal people here in Brisbane. I'd like to pay respects to elders past, present and emerging. And I'd also like to extend that respect to any Aboriginal or Torres Strait Islanders that might be joining us in the room, in webinar land. So thank you. Today, it gives me great pleasure to introduce somebody that's actually done webinars for us before, so it may be somebody that's familiar to you. And it's also part of our QScript series. So we had one a couple of weeks ago, then we had a break, and now we've got about, I think it's 4 more QScript presentations in a row. So I think it's going to be interesting for you guys to join us to kind of learn the landscape of what's coming at the end of this year when QScript hopefully gets launched in Queensland. And I think today's presentation is going to be useful because for those of you that don't know, next week, the 31st of August, is International Overdose Awareness Day. And it's a day when we acknowledge that many people unfortunately lose their lives as a result of the dependence on their substances. And without a doubt, the substance that has the highest rates of death associated to it are definitely opioids. So I think today is going to be an interesting presentation in line with what's coming up. So today we've got Associate Professor Suzanne Nielsen. She's Deputy Director at Monash University's Addiction and Research Centre down in Melbourne and definitely knows this subject inside out. And she's going to be presenting today on having meaningful discussions about opioid-related risks. So without too much further ado, I'm going to hand over to Associate Professor Suzanne Nielsen. So thank you, Suzanne.
Great, thank you. Thanks for the warm welcome and for having me back. And as mentioned, I have presented on some of this work before. What I'm going to talk about today is hopefully to advance the idea of identifying and discussing opioid-related risk and start to think about how we can integrate the kinds of things that we do to identify risk with the kinds of alerts and information that we might be getting when we move towards having QScript in Queensland. And Queensland is certainly not the only state that is moving towards having real-time prescription monitoring. We're seeing that's going to be emerging in many states of Australia. So it's become a very topical conversation. See if I can advance my slides. Here we go. I also want to acknowledge the traditional owners of the land on which we are all present today and pay my respects to elders past, present and emerging also. So to give you a little bit of an overview of what I'm going to talk about today, I'm going to cover tools which are going to assist with identifying clinical risk with opioids. I'm also going to provide a little bit of an overview of what the difference might be between what QScript algorithms might identify and the risks that we might identify with clinical outcome tools, and then how to bring those two things together a little bit in our clinical practice. I'm not going to cover a lot of specific information about the software, but I do want to give a shout out to the Queensland Health website, which already has a lot of information that you're able to access if you want to find out how the software is going to work, how to register to use the software, and then lots of also other relevant clinical information to help you become prepared to be able to work when QScript comes online. So I will touch on a few of the kind of details of the algorithms, but I'm not going to go into details about how the software itself works, but that information is available. So I would encourage anyone who's a healthcare professional in Queensland to head over to that website to register and to start to look at that information. So I just want to give a little bit of background as to why we're talking about this. I don't think this information is going to be new to anyone here, but we have seen that the overwhelming majority of opioid-related deaths in Australia are from prescription opioids. So you can see here on this graph, this kind of teal, aqua color, whatever you'd like to call that, is our prescription opioid-related deaths. And you can see while heroin-related deaths have been rising in recent years, we still see the majority of deaths are due to prescription opioids. Now, Amanda Roxburgh has presented data that gave a really nice overview of the nature of these deaths. And from that data, what I did is just pull out the deaths that were looking, that were involving opioids that are only used for pain. So fentanyl, morphine, oxycodone, tramadol, codeine. So not looking at methadone and buprenorphine. And when we look at those deaths, we see that half of those actually involve people with chronic pain. And the overwhelming majority do not have any history of injecting drug use recorded. So I did just want to highlight the fact that we see a large portion of these deaths are involving patients with chronic pain, and that we have this opportunity when we're interacting with patients with chronic pain through pharmacies, through prescribing, and through seeing alerts on QScript, that we might be able to make a difference in the trajectories of these people's lives. So again, looking at opioid-related risk, we actually know it's quite common among people who are using long-term opioids. So it's not a small number of people that might have some form of risk. We know that 1 in 4 people who are prescribed long-term opioids meet criteria for addiction as defined by the American Pain Society and others. It's a slightly different percentage depending on what definition you use, but it's not insignificant, the number of people who might run into problems with opioids in that way. We also know that that's not the only kind of risk that exists. So we've seen 4 in 5 people who are prescribed long-term opioids meet criteria for overdose risk. Yet among this population, very few of them have knowledge of what that constitutes or how to respond or reduce their risk. So it is a broad problem that we see amongst people who are prescribed long-term opioids. Again, and this is from findings from the POINT cohort study led by Louisa Degenhardt, we see that half of those people who are prescribed long-term opioids are actually worried about their own opioid use, but very few of them will receive help, often because very few of them will ask for help. And we also see that often healthcare professionals aren't confident in how to tackle these conversations around opioid-related risks. So I'm hoping that the conversation we have today will help move people along to feeling more confident, and also some of the information that you'll be able to access through prescription monitoring will again give you more of a complete picture to be able to feel confident to identify risk. So I did want to start by talking about what is prescription drug monitoring, because I think a lot of people have different perceptions. And I think the overwhelming thing that we hear when people hear about prescription drug monitoring is thinking that it's a program that will help them catch people who are doing the wrong thing. And I think that's kind of an oversimplification. You know, maybe it'll be tell them who not to supply opioids to. Again, that's an oversimplification, and I don't think that's a good clinical outcome if that's people's perception. So from my understanding, I think that the best way to conceptualize it is an information system. So it'll give you information about medications that are supplied and dispensed. It'll be a prompt for you to look into more detail into a patient's history. And it'll also provide you some alerts based on algorithms, based on what medications that somebody has had supplied. Equally important is to think about what it's not, and it's absolutely not a clinical decision. A prescription monitoring system will not tell you what to do. It will not tell you if a medicine is appropriate for the patient in front of you. And it also won't tell you that you cannot supply a medicine. It's just going to give you information that will help you decide what the appropriate path is, and to flag where you may need to gather more clinical information before supplying or before kind of making a change in a patient's plan. So based on the information on the QScript website, these are the kinds of alerts that we're going to be seeing. And when you receive an alert, it will tell you what kind of alert it is. So that's very helpful in working out what to do. So the kinds of alerts that are there are alerts for high opioid doses, so a dose of more than 100 milligrams of oral morphine equivalents. There are alerts that will tell you that somebody's receiving an opioid and a benzodiazepine, and we know that that combination of medicines is really overrepresented in our mortality statistics. So we see, for example, the average drug-related death in Australia is a middle-aged male who is prescribed opioids and is also using other substances, commonly benzodiazepines. There are alerts to tell you that someone has seen 4 or more prescribers in the past 3 months. Now, that's a relatively low threshold for somebody who's seeing specialists, in addition to maybe being at a GP clinic that has multiple prescribers. It would not be impossible to see for prescribers through routine care. So again, it's a flag that you might need to look into that more to identify if those prescribers are all aware of the other prescribers. We have flags if someone has been on opioid dependence treatment in the past, and I would urge people to be very cautious in how they interpret those flags, because people who have had opioid dependence in the past may have very legitimate needs for analgesia, and we certainly don't want to stigmatise people as a result of seeing that flag. And there are also flags to let you know that somebody is starting on one of these higher risk medicines, and that might be a flag to have a conversation around ensuring that where it's not intended to be long-term, that the right things are put in place to ensure that doesn't happen. So those are the kinds of things that might trigger alerts. In general, I'm going to talk about alerts without sort of going into detail about which one, but you'll see how that goes as we go through this conversation today. So the first thing that I wanted to talk about is dose, because it is common to see these high dose alerts. And I wanted to just let you know about some recent research that we've done that's looked at how much dose explains in terms of someone's risk. And actually what we see is that dose, it is a good measure to identify an at-risk population, but on its own, it doesn't explain that risk. And when we actually look at multiple factors, we actually see a lot of that risk is explained by things such as those on high doses being much more likely to also have more severe pain. They're much more likely to have significant mental health comorbidity at the same time, to be using extramedical pharmaceuticals, and also to be prescribed pharmaceuticals that might increase their risk. So prescribed benzodiazepines or atypical antipsychotics, pregabalin, other at-risk medicines at the same time as opioids. And we also see that those with higher doses are more likely to also have other substance use disorders or substance use. So while we see dose as an indicator for risk, all of the risk isn't associated with the dose. And if we reduce the dose, it doesn't necessarily reduce the risk if we don't address all of these underlying comorbidities. So somebody who's on a high dose, if you halve the dose or cut them off their dose, their risk might actually go up if you haven't supported them and provided appropriate care for all of those other comorbidities. So it is really important to be thinking about the whole person and not just looking at a dose. So how do we put this information together? How do we identify risk among people who are receiving opioids? And where does the information that we get from prescription monitoring fit into our clinical decision-making? So at this point, I wanted to highlight some recent research we've got just to kind of contextualize the information I'm going to provide to you. Louisa Pico is a PhD scholar from the Monash Addiction Research Centre, who I'm lucky enough to work with, and this is her work that I'm presenting on this slide and the next slide. And so this is just to give you a bit of a snapshot about how the information that you might get on QScript or a PDMP alert might differ from some of the clinical information that you get. So this is from a study of 119 people who are on long-term opioids, where we used the algorithms that we know are used to create alerts, and we worked out of those patients based on their medication history, who would receive a PDMP alert. And this is alerts for high doses, medicine combinations, etc. And then we looked at using validated screening tools, what kind of clinical risk these patients would have. And this is an example here where we looked at opioid use disorder. And what you can actually see is the majority of people who meet criteria for an opioid use disorder actually would not get a PDMP alert. So many of those are on lower doses, yet they still have clinical risk associated with their opioid use disorder. We also see no correlation between the PDMP alert and opioid use disorder. So the prevalence of opioid use disorder in people with alerts and without alerts, is pretty comparable. There are a small number of people who would get a PDMP alert and also meet criteria for an opioid use disorder. So of these 119 people, 12 people would actually meet both of those risks. And the care that they might need might be different to somebody who only got one or the other of those alerts. But what we see is if we just use an alert and we don't have that extra information, we might be missing some really important pieces of the picture. And so an alert doesn't equate to having a problem with opioids, I guess is what I'm trying to say here. And we need to kind of look at it more broadly than that. So to give you a little bit more of a picture, and this again is Louisa's work, that we drilled down to the 16 people of those 109 people 119 people who would have received a high dose alert. So these are people who are on this 100 milligrams or more of morphine equivalents. And what we saw is the majority of them actually would have met at least one at-risk indicator using the ROOM, which I'll talk about later, a routine opioid outcome monitoring tool. And we know that risk amongst people who are on long-term opioids is fairly broadly dispersed. Many people have risk factors. But when we look at the most common risk factor among those who are getting a high dose alert, it's actually that they've got severe sort of unmanaged pain. And so if you think about if the response to an alert was to not supply medicine, and you're looking at a population that have severe and unmanaged pain, the impact of that, in terms of causing people distress and the clinical outcomes probably isn't what you would intend. We actually see the next most common risk factor is having low mood. So when we think about those receiving alerts are likely to have unmanaged pain and a reasonable amount of distress, we want to be really careful in terms of the responses that we put in place for those groups. And again, you can see we had only 5 of those 16 people on these high doses actually met criteria for an opioid use disorder. So we don't want that assumption that an alert means that somebody has opioid dependence to drive our clinical responses, or we might miss actually the treatment that they need. And so I like this image of the giraffe sort of doing the painting of the lady with the hat, because I think this is a nice kind of idea of what we can have with prescription drug monitoring. And if you've got that viewpoint of these high dose alerts, you will certainly see a piece of information, but it's not going to give you that whole picture. So the PDMP alert, it can trigger a clinical review, but it won't tell you what you need to do to manage the risk for a patient. And you also need to be aware that many patients who are at risk won't get a PDMP alert. So you still need to continue to use all of your clinical judgment that you're using to provide appropriate care for people, even when your prescription monitoring might show you that they're green, they don't have an alert that you need to look into the system, but we still need to think about the risk with opioids more broadly. So what tools are available for clinical review to get that more complete picture? I guess in terms of what we need to measure, kind of depends on what risks that we might be worried about. And if people like using the chat box, I would welcome you to enter into the chat box things that you might think are clinical risks that you're worried about. There are a whole range of things that we worry about with opioids. And it's not just dependence. So I'll just I'll give you a bit of a short list of the sorts of things that I think that we're often talking about. Obviously, with International Overdose Awareness Day coming up next week, overdose is something that is in the front of our minds. We also might be worried about opioid dependence, also known as opioid use disorder, or commonly referred to as addiction. But we also have these other things such as, is someone's pain not well managed? Are they getting excessive supply, having excessive supply in the home that might put them or others at risk? Are they seeing multiple prescribers, and what might be behind that? So there's a whole bunch of things that we want to be able to identify. So I wanted to talk firstly about opioid use disorder, not because it's the only concern, but it's often one that people feel least confident around. So opioid use disorder, often called addiction, commonly called addiction, it's got a range of diagnostic criteria. I know there's a lot of words on this slide, but I just wanted to go through the common features. So with opioid use disorder, we see that opioids are often taken in a larger amount over a longer period of time. People have often been unable to cut down or control their opioid use, and they're spending a lot of time focusing on opioids. They experience craving, they're perhaps not doing their other kind of things that they need to do in their lives or fulfilling their other obligations. And they often might have be continuing to use opioids despite experiencing a range of problems. They might be giving up things that are important to them because of their opioid use and placing themselves in risk in a range of ways. Now you can see at the bottom of this slide that having tolerance and withdrawal are features of opioid use disorder. But if somebody is using opioids just in a medical context, that actually doesn't contribute towards a diagnosis. Addiction or opioid dependence is another diagnostic criteria. You can see just from looking at this, these are very similar. So whether or not you're using the DSM-5 opioid use disorder criteria or the ICD-10, which is the WHO opioid dependence, we're looking at a lot of those same features. So compulsive use, difficulty controlling substances, potentially having withdrawal and tolerance again, which we expect with long-term medical use. and persisting to use substances despite experiencing harm. And again, there's kind of a lot of time to access opioids and losing interest or neglecting other important things in people's lives. So that's what we're talking about when we're talking about opioid dependence and opioid use disorder. I'm going to now talk about a very brief tool that you can use to identify opioid use disorder. It's not the only way, but it's one thing that you might do if you're wanting to assess clinical risk with someone. So I'm going to talk about the OWLS, which is a tool that we've done research developed. It's brief, it's really easy to score, and we've developed and tested it with people with chronic pain, which I think is really important because there are a lot of tools out there to assess opioid use disorder, but often they were developed in people who use heroin, and the wording and the language isn't really salient or relevant to people who use prescribed opioids. We have shown that this tool is also acceptable to consumers, and I've got a QR code, so if you download the slides or if you have your smartphone handy, you can actually access this tool and download it for free. All of the tools that I'll talk about today are available for free for you to use and download as much as you find useful. So this is the questions. It's a four question tool. Essentially, for each of the questions, people can say not at all. They would score a 0. They could say that they endorse this symptom a little bit, a lot, or a great deal, and then they would get a 1 for the score. So even though we've given this sort of gradient, people, in terms of scoring, it's either present or absent. So the kinds of things we ask about is if somebody has been using their opioids for other purposes, for example, to help with sleep or stress or worry. If people are experiencing feeling slowed down, sedated or sluggish from their opioids, so getting that as a side effect. If opioids are causing people to lose interest in their usual activities. And also if they're worried about their use of opioid medicines in the last 3 months. So these 4 questions. So we've called it the OWLS. It's an easy way to remember that. So overuse or use for other purposes, being worried, losing interest, and being slowed down, sluggish, or sedated. So again, just to reassure people that these are tools that have been developed and validated, you can read those published papers, although you certainly don't need to be able to use the tool. So in terms of if we're scoring the OWLS, a positive score means that you've endorsed 3 out of 4 of those items. And that would be a prompt that you might need to do a more detailed assessment to see if somebody does meet criteria for opioid use disorder. So either using the DSM-5 or the ICD-10 criteria that I mentioned a few slides ago. We know that people with opioid use disorder are particularly at increased risk of opioid poisoning or toxicity, which is often commonly referred to as an overdose. And then if we identify that somebody on long-term opioids for chronic pain is meeting criteria for opioid use disorder, it's a really important time to reassess the risks and benefits of opioids from that patient's perspective to see if opioids are the best option for them to manage their pain. They might need additional strategies in place to manage their opioids. And if it's a more severe opioid use disorder, it might be the point that we start talking about opioid agonist treatment like methadone or buprenorphine, which means that they don't necessarily need to cease opioids, but we can transfer them onto an opioid agonist treatment and have opioids provided in a much more structured and safe way. And particularly we know that buprenorphine has much lower risk of opioid toxicity or overdose, and that can really save lives in terms of putting somebody onto a safer opioid and having a bit more structure. We also know that many people might endorse one of these symptoms, and that doesn't necessarily mean they meet criteria for opioid use disorder, but it does mean that they probably need a clinical response. So the 4 questions, and I'll just go through them one more time, is that if they're using opioids for other reasons, so for example, for sleep or stress. If you've done this tool with someone and they say yes, that they are doing that, even if they say no to all the other questions, you might want to explore for them, what's going on for them. Is their insomnia related to their chronic pain? Are they feeling stressed? Have they got other things going on in their lives that's making it difficult to manage both their stress and their pain? And can you put an appropriate clinical response into that might reduce their risk around opioids? If someone says that they're worried about their opioid use, again, if they haven't endorsed any of the other questions, you might want to be finding out why they're worried. We do know, for example, in palliative care, some people are worried about opioids because they're worried about developing dependence, so they're not using enough opioids to manage their pain. So worry can come in many forms, and about if you can understand what people are worried about. You know, are they worried about access? Maybe they're worried about being cut off their opioids. If we can understand if they've just endorsed that symptom and none of the others, what's going on, we might be able to reassure patients. If people say that they're losing interest in opioids are becoming a focus in their life, again, this is consistent with an opioid use disorder, but it could also be that there's other things going on for someone, and we can try and unpack kind of understanding their comorbidity and depression. And then in terms of if they're feeling slowed down, sluggish or sedated, these are important side effects from opioids. It may mean that the dose is too high and that a lower dose might be more appropriate. It might mean that they have got interactions with other medicines that they're on. So benzodiazepines, I can see some comments on atypical opioids. So we can talk about that at the end. Atypical antipsychotics, pregabalin, all of these things might mean that somebody is experiencing sedation, and we know that impacts on people's quality of life. If people are sedated, they're not able to get out, they're not able to do the things that they're enjoying, that's not necessarily a good outcome with opioids. And maybe if we're seeing this, it could flag that a home medicine review, for example, with a pharmacist might be good to kind of assess what's going on there. So none of these things on their own should suggest that opioids should be ceased. And I would never recommend, based on a brief 4-question screener, that somebody's opioids are stopped, but it does give you clinical information to try and work out what is the next step with that patient. So I've got a bit of an algorithm here, but I want to tell you know that this is not the answer, and I will keep developing this kind of concept. But this is one way that I could imagine people might implement using something like an opioid use disorder screen. I actually don't think this is the best case scenario, but I just wanted to walk you through what it could look like. So for example, you might get an alert on prescription monitoring and you might think, oh, maybe this person has an opioid use disorder. You do a screen and you find out, no, they don't meet those criteria. You still want to think about other clinical risk factors. You might do a screen and identify that somebody does meet criteria for opioid use disorder. Then you need to start thinking about, well, what's the appropriate clinical response there? Is continuing on these opioids for pain going to be best for them? Do they need more structure? Do they need stage supply? So maybe picking up every couple of days rather than every 2 weeks or every month to reduce their risk. It might be you start thinking about methadone and buprenorphine depending on the severity of the clinical picture. And you might be talking about addiction medicine specialists to make that decision. I would certainly hope that you're thinking about providing naloxone for that patient and educating them about opioid risk. But you certainly need to be thinking about the whole picture. And just doing an OUD screen with the owls is not enough to tell you that, in my opinion. So while I think it would be really great if we are screening for opioid use disorder as part of a risk profile, I don't think that's the whole story. And I've got these faces that are going to pop up through my talk. And this is based, I'll just show you here, from the Wong-Baker Faces Pain Rating Scale. I'm not going to talk about this rating scale, but I just wanted to say that I would put this response here in a kind of a middling response. I think that we can do better. It doesn't hurt me as much as if you were just going to make a clinical decision based on a PDMP alert. But I don't think this is the best response. So let's keep going and see what else we can do. I think best practice is accepted to be routine monitoring of outcomes with pain medicines, and is based on this 4, and it's become 5 A's, and I've actually made it 6 A's, and I've talked about this in the past in this webinar series. The best practice in terms of monitoring risk is really looking at more holistically what's happening when someone's pain medicine. So looking at the analgesia, what relief they're getting from their medicines, but also how well they're functioning. So activity is the second A. Looking at any adverse effects that they might be getting from the medicines, looking at addiction-related or aberrant behaviours that might be occurring with these high-risk medicines, and also looking at mood or affect. We know that's very important. And then I've added on alcohol as a risk, and I will talk about that more in a few minutes. This is the basis for the routine opioid outcome monitoring tool that I'm going to talk about. And it is really important that we're monitoring for more than just addiction or aberrant behaviours. So again, this tool is available for you to download if you think this would be useful for you in your clinical practice. It's got 12 questions and it links very closely with these 5 A's that were developed more than 20 years ago now by Pasek and Weinreb. So we can see here how these tools map. We've got analgesia and activity covered by the PEG, adverse effects, addiction with the owls, affect and alcohol. So let me walk through what that looks like. Again, just to reassure everybody, I'm not going to go into detail about the validation studies that we did, but they have been validated in people prescribed long-term opioids, and we've demonstrated that these tools are acceptable to be used in patients through an implementation study. So this is the PEG. Many people might be familiar with this. Just to very quickly show you what's in there. It's a 3-item tool where people score between 0 and 10, where 0 is no pain or does not interfere, and 10 is as bad as you can imagine or completely interferes, for example. So when we look at this, we get a score out of 10 for someone's pain on average. We get a score out of 10 for how much pain has interfered with someone's enjoyment of life, and a score out of 10 for how much it's interfered with their general activity. You can consider those questions on their own, or commonly what people will do is add up all 3, divide it by 3, and then that'll give you an average score out of 10 to give you an idea of how severe someone's pain is. And in general, sort of 7 or above is considered severe. And if someone's on opioids and is getting a score of 7 or above, it suggests that their pain is probably severe despite being on opioids, and that their pain may not be well managed. I'm not going to go over the owls again, but this is the 4th to the 7th question on the room tool. And then we've got affect or mood. We know that around half of people who are on long-term opioids will have moderate to severe depression. And sadly, 1 in 5 have attempted suicide. So it's not uncommon in this population. This is a high-risk population in terms of mental health. And so this is a brief screen that's really well validated for use in primary care settings. Slightly different to scoring of the owls, where you get a 0 is not at all. If someone reports these symptoms on several days, they get a score of 1. If it's more than half the days, they get a score of 2. And if they report experiencing these symptoms nearly every day, a score of 3. So the patient is asked in the last 2 weeks, have they had little interest in doing things, or have they been feeling down, depressed, or hopeless? And so depending on the score, you just sum these 2 scores, and a score of 3 or more indicates that you do need to look into that more carefully, and that person might be experiencing depression. In terms of alcohol use, this is the 6th A that I mentioned, and we know that among people with chronic pain who are on opioids, 1 in 3 report a lifetime alcohol use disorder. It's not uncommon. We also know that alcohol can really have negative effects in a range of ways. So we see it's commonly implicated in opioid-related deaths, but we also know that alcohol can interact with people's medications. It can really impact on management of things like, diabetes, for example. It can affect sleep, and we know sleep is really problematic for people who have chronic pain. So thinking about alcohol as part of the clinical picture is really important. And I think we are absolutely moving along to be thinking about alcohol use is something that we should be asking about, just in the same way we ask about if people smoke. We should be regularly questioning that because of the risks around alcohol use. So the single question that's in here is if somebody is consumed more than 4 drinks for women and more than 5 in a day for men. It's a single question, but it correlates really well with a lot of those longer tools to identify people who are at risk. If somebody positively screens for this, so that's saying 1 or more occasions in a year, and we know that that's risky for people who are on opioids, then you would do a more detailed screen. In terms of if you get a positive screen, and I just want to do a bit of a shout out for the REACH project here. Again, a QR code, you can download these resources. There are lots of really kind of newly developed resources for doing brief screening for alcohol. It's not a new thing. There's lots of old resources as well. But if you wanted to look at how you would manage this, that information is available. Essentially, if somebody has risky alcohol use, it's appropriate to do a brief intervention. A 5-minute intervention has been shown to a 5-minute discussion to cause a significant reduction in alcohol use in a population level. If somebody meets criteria for opioid use disorder, that's when we would be referring them for treatment. So you wouldn't necessarily be able to respond with a brief intervention, but if you can identify that in a primary care or pharmacy setting, then you can get someone's needs appropriately met. We do have constipation in there. Again, this doesn't necessarily contribute to opioid-related risk in terms of overdose, but it does really affect people's quality of life. And so we do have that in this routine opioid outcome monitoring tool. We know that constipation is common. We know that lifestyle factors can be important. And we also know that often people are not on the right laxative if they have opioid-induced constipation. So I'm not going to go into a great amount of detail about it today. It's not the main topic, but I did just want to flag that it's useful to screen for this as part of the tool, and that there's great information if you want to learn more about opioid-induced constipation. So now I wanted to get on to thinking about a more holistic approach. So we've got here, you've got an alert from QScript, a red alert's popped up and you think, oh, there's clinical risk for this patient. That doesn't mean that you can't supply opioids, but it does mean that you probably need to work out where that risk is and then develop a plan that's specific to that risk. You could use the room tool, which I just walked through. You don't have to use the room tool. If you've got another way that you are comfortable to assess this kind of risk, absolutely use that. I'm giving this to you as one example, but it's definitely not the only way. But for you could use a room tool or any other risk assessment, and then you identify that there's no other risk factors. That's great. You could still consider using offering naloxone if someone's on a higher opioid dose, and generally we're recommending anyone on 50 milligrams or more of oral morphine equivalents should be offered naloxone, or if they've got a risky medicine combination or other risk factors such as COPD, we'd be thinking about offering naloxone and making sure that somebody in the home knows about what naloxone is, how to use it. I will give more information about that at the end. We also might be wanting to start to think about whether or not they're still getting benefits from opioids. So even if there's no risk, it's still useful to keep revisiting, is this patient getting benefits from their opioids, and thinking about whether or not a slow taper might be appropriate, but there's no need for an urgent response there. If we look at room and we identify some kind of clinical risk, then we can start to put in a targeted response. So if we identify that they have unmanaged pain and there's a QScript alert, we need to start thinking about how can we get a better pain response in place for that person. If they do have alcohol or some other drug-related problems, risky alcohol use, they're meeting criteria for opioid use disorder, then we might be thinking about an AOD referral. And again, I've just tagged naloxone on there. I think we should always be thinking about naloxone as well. So where supply might seem unsafe or inappropriate, we would more urgently want to be getting support or referral. But I again would encourage people not to be ceasing opioids suddenly based on these risk factors. You might only want to supply a day or two. You might want to put other things in place immediately. But we know that suddenly ceasing someone's opioids can actually put them at increased risk. So to try and avoid that wherever possible. So this is like one more step up on my pain scale. I'm feeling less pain now if we can put this in, but I still think there's a better way to do this. And just to reinforce why I think there's a better way to do this, I just wanted to kind of just remind people. So this is based on using the room tool and a sample of community pharmacy patients. We found that 4 out of 5 actually had one risk factor. We're going to find whether or not somebody has an alert on QScript, they probably have some level of opioid-related risk that needs to be responded to. So if we are only doing this sort of risk monitoring in response to a QScript alert, I think we're going to miss an important part of the picture. So we can see, for example, of a sample of 152 people who are on long-term opioids, we see around 3 in 10 are on a high dose, around 2 in 10 are also on benzodiazepines. We have around 4 in 10 with opioid use disorder, around 4 in 10 with risky alcohol use. This risk is widely dispersed. The other reason that I think it's really important for us to take this broader approach is, again, looking at this wonderful work done by Louisa Pico, PhD scholar, who works with me. She actually did a factorial experiment to look at what factors might trigger someone to not supply opioids. And so using this kind of experimental method, testing a whole range of different factors to see what predicted decision-making. And she looked at patient factors, she looked at clinical risk, she looked at comorbidities, and she looked at prescription drug monitoring alerts. And what we actually saw is, by a really long way, PDMP alerts were the biggest predictor of somebody being less likely to supply opioids to a patient. And that many of these other known risk factors actually didn't influence that supply decision. And so the conclusion from this work is that it seems that sometimes these alerts play too much of a role in clinical decision-making. And this is a well-known phenomenon known as automation bias. When the computer goes ping, often people will forget all of those wonderful kind of well-developed clinical things that they already know and think that the computer is going to know better and have that drive their decision-making. So based on that, what I think is probably a much better approach, and this is what I would recommend people try and think about when they're integrating QScript information into clinical practice, is to have a combination of your QScript information, but also your clinical assessment, whether that's the room or any other kind of biopsychosocial assessment, to identify what's going on for a patient and combine these two sources of information to make a clinical decision. And again, if we're not identifying risk, there's no other risk factors, we can still think about naloxone if it's relevant. We also might want to think about a slow opioid taper if there's limited benefits from opioids. If we do identify risk, then we want to look at the nature of that risk. We want to have a targeted response, again, that speaks to that risk. And it may include an opioid taper, but it might also include a plan that has greater supports. Importantly, we just want to avoid that sudden cessation. So this is our best case scenario. We're assessing risk with all patients because we know that many at-risk patients actually won't get a QScript alert. We're addressing that clinical risk. And we're considering a long-term plan and whether or not that long-term plan will include opioids, but we're not having a risk assessment driven only by a PDMP alert, and we're not having a supply decision driven only by a PDMP alert. And I just wanted to this is my very happy face. I think this is the best case outcome if we're able to integrate this information from QScript in this way. And I also wanted to just give a shout out to Nicolette Ellis, who I can see is online now, who I think gave a really fabulous presentation on navigating, talking through these risks with patients. So if you're watching this and you're thinking, oh, I don't know if I can have this conversation, I'd really like more information, I would really encourage people to go back and check the back catalogue of Insight webinars, because I think this will help us think through this kind of risk versus benefit for the patient and whether or not they might want to consider an opioid taper, even if they're not meeting risk criteria, because of some of the other benefits of coming off opioids in the long term. Now, you might come up into a situation where you think there's a really significant risk for a patient, and you know that I have said a number of times, please don't cut patients off their opioids because of an OWL score. Please don't cut patients off their opioids because of an alert on the prescription monitoring. But what can you do if you think there is really significant risk today? So there's a number of options that I would consider that you should be thinking about. Staged supply is really a great option if you want to keep someone safe in the couple of days that it might take you to put another response in place. So, a couple of days supply, you're not cutting them off their opioids. They're not leaving worrying about how they're going to manage their pain. But you're not giving them such a large amount of opioids that you're worried about their safety in the longer term. Naloxone, I'm going to talk about in the next few slides, but I think it's really important. But also thinking about who you can consult with. Now, I was able to pull this for Queensland in terms of the phone consults with addiction medicine specialists. So this is a free service. I've made the number a bit larger there, so you can ring that 7 days a week to get advice. There are also pain services. I think that they might be more localised, so you might need to find out what the number is in your region based on where you are in Queensland. But there are local consults that you can do if you're worried about pain management and a patient that might be having an alert in prescription monitoring. So also thinking about who you can reach out to in the short term. So for the last few minutes, I did just want to talk about that naloxone, the idea and how we do overdose education for people who are prescribed opioids. We are getting to the point now where it seems like for anyone on long-term opioids, that risk is so widely dispersed that it probably is worth talking about opioid safety. We've given this 50 milligram OME cutoff as a bit of a rough guide where that risk increases, but we do know we have overdoses in people on lower doses, particularly if they're on a lower dose with other comorbidities. So I would really be encouraging people to talk about opioid safety with anyone who's on long-term opioids. Perhaps not if you've got a single prescription for Panadine Forte, after procedure or tramadol, but definitely when we're seeing people on long-term strong opioids, I think this is a conversation we can have. I'm not going to play this video for you, but I want you to know that we have developed an animation. It's only a couple of minutes. You can view it and show patients this animation from the QR code on the screen, or you can email me if you want me to send you the links. This is an animation that's developed to put the concepts of opioid safety, naloxone, framed in a way that makes sense to somebody who's prescribed opioids. So we know there's lots of wonderful resources around overdose education for people who use or inject drugs, but they aren't necessarily targeted for people with chronic pain. So in a collaboration with Monash and Turning Point and funded by the Victorian Department of Health, we're able to come up with these resources that are specifically for those people who are prescribed opioids for chronic pain. So there's a short video there. There's also a leaflet that you can download from there for patients to be able to have those conversations in ways that make sense for people who are prescribed opioids for chronic pain. Just to give you an idea of the resources, there's a health professional version here. It covers key information to tell patients, and it's also got a range of conversation starters of how to raise this with language that's appropriate for people who are prescribed opioids for chronic pain. And then we also have a complementary patient leaflet that has an opioid safety plan here. It gets them to record where they've stored their naloxone at home. And this is something that you can walk through with a patient and their carer, ideally, so that they know where the naloxone is and what to do with it. And this is in response to the fact that we know that most people who are prescribed opioids aren't actually familiar with the signs and symptoms of opioid toxicity. Very tragically, we often see that people will die in the home with somebody else present that didn't necessarily identify those symptoms. So this education is really critical. And these are just a few of the kind of screenshots from these animations of key information of normalizing naloxone, explaining how to respond in an overdose, but also how to prevent an overdose, language and how to use naloxone sort of fairly simply. And now we have this nasal spray, which is a single dose in the nostril, repeat after 2 to 3 minutes. It's fairly straightforward to explain to patients. So that's all of the information that I wanted to go through today. I know it's a lot of information, but I just really wanted to try and contextualize where we fit this PDMP information in with our opioid risk assessments. And I would conceptualize it as a piece of the puzzle. It's not the answer, but it can be a really useful tool for identifying where there might be risk. You're able to then look at a comprehensive history of everything that someone's been accessing to find information about medicines that you might not have known that they were on. If we combine that information with a clinical assessment, I think we can get a much more complete picture, and it'll actually tell us what we might need to offer a patient in terms of a plan. We do know that most patients who are prescribed opioids have really meaningful levels of risk associated with the opioid use. But that risk isn't all linked with opioid use disorder. And as I showed you early on in this presentation, it's only going to be a minority of patients who get a prescription drug monitoring program alert that will actually meet criteria of opioid use disorder. Most won't. And many patients who are at risk won't get an alert. So putting those two together, I think, is ideal. For the final time, I will say to avoid abrupt cessation of opioids, we know that this actually increases patients' risk in the short term. And then we want to consider, again, looking at if those longer term risks outweigh the benefits and having conversations with patients about whether or not they might want to come down in their dose to reduce that risk. But I think that's best done considering the whole picture. And it doesn't necessarily, you don't have to wait for an alert to have that conversation with patients. We can start to be talking about those conversations with patients now who are on opioids and might have benefits, fewer side effects, fewer effects on their life from opioids if they were able to reduce their dose. I do want to acknowledge I presented work today that comes from work that I've done with a lot of different people. It was funded from a lot of different sources. So just to acknowledge all of those people and funding sources. And also just to make my email address available to you if you've got questions that we don't get to today, or you can also contact me via Twitter. I am really open to continuing this conversation with people if you'd like more information about these resources at any point in time. So that's the end of my formal presentation, but really happy to take questions. I couldn't follow the chat very closely, but I could see that that was going on in the background.
Thank you, Suzanne. An excellent presentation, and as you say, there was plenty of stuff coming up in the chat, which I've got some down, so we'll go through a few, as I know you've got a few minutes to be able to do that. But firstly, I do want to say a big thank you for a really thorough presentation. It's always a pleasure to hear you talk because of the knowledge that you carry, and it's also useful to have a refresher of some of those tools and how we can apply them, and the importance of looking at that total picture and not relying on just one piece of information that we have. So thank you for that. If it's okay, I'll run through a few of the questions.
Yeah, absolutely.
So somebody's put, you mentioned a lot about, or not a lot, but you mentioned about the combination of opioids and antipsychotics. And I know obviously some of those are drugs of interest in QScript. Is it the same for all atypical antipsychotics? If you know this, I'm not sure if you'll be familiar, but somebody's particularly asked, is it due to the sedating effects of typical atypical antipsychotics? And does it apply to some of the more stimulating ones, such as Abilify? So Abilify is an agonist of dopamine and an antagonist of serotonin, which is kind of unusual for an antipsychotic. And they were just asking if that sedating effect is the same with opioids with Abilify.
Look, I haven't seen that popping up in some of the harms data that we've got as often as things like quetiapine in particular. I think quetiapine, when we're getting a bit of a safety signal around that in combination with opioids. And again, that can be a proxy for a higher risk population. But we were seeing quetiapine being used non-medically. And again, that can increase the risk. I haven't seen Abilify popping up as much in that. But again, if we do, I guess it's more of the whole picture. So, if they're on, perhaps, a lower dose of opioids and Abilify, and everything else is clinically well managed, you might not necessarily be worried. That's quite different to somebody who may be on a higher dose of opioids. They're on multiple sedating or CNS medicines. But maybe they're drinking as well on top of that. That's quite a different clinical picture. So yes. I wouldn't be specifically worried about just seeing Abilify and opioids if everything else looks okay and is well managed. But it might be something that triggers, oh, what else are they on? Does the whole picture look reasonable? And maybe I still have a conversation about naloxone and make sure that somebody in the home would identify those symptoms, just to be sure.
Definitely, I couldn't agree more. And we'll come on to naloxone because we do have a question about that. Yeah. You did ask during your presentation, for people to put in the chat if there were any particular areas of concern around the opioids. And some did actually type in that in their, I assume in their field of work, opioids and clozapine. So, quite an old-fashioned antipsychotic used as a last resort. They're a particular risk for people with serious bowel issues. I assume that's in her line of work, and she just put that in as a comment. So I know we often lose the chat, so I just didn't want you to lose out.
Yeah, and I do think, that's the reason we've sort of popped like the constipation at the end of the room tool as well. It's like thinking about those other side effects with opioids and how they might actually be exacerbated by other medicines is important. It might not mean that somebody has an overdose, but again, as you can say, we can have serious bowel issues that could be potentially fatal. Not all opioid-related problems are overdoses, and so being able to identify all of the risks is important.
Definitely. Do you think the message, so one of the clear messages from today is, just because you get an alert doesn't mean that somebody has a substance use disorder that, we need to panic about. And obviously this is an excellent presentation for people to come and have a look at and learn that. But assuming that all the people that access or will have access to QScript don't see this presentation, is that message being distributed to the people that will be seeing those alerts? Because obviously stigma is something that we're working very hard to break down, and potentially that could increase if people don't get that education.
Yeah, look, I've had a number of meetings with people who are involved in the QScript implementation, and I think they are absolutely across this as an important issue. So I am confident that that messaging will be echoed across multiple platforms. I think it is on the front of people's minds. Obviously, if people aren't attending the training or getting that information, that might be a concern. But I do think that that is something that we've been talking about a lot. I think that the QScript kind of experts are really on top of this issue. But again, if you're having conversations with colleagues and you have the opportunity to share that information as well, I think never miss an opportunity to make sure that we're not adding stigma or kind of having inappropriate conversations.
Yeah. And I think that's a fair point, that we all carry the responsibility to pass on what we know. So, yeah, no, I agree with that. Thank you. In one of your slides, when you were talking about risk factors, one of the big risk factors that you identified was the unmanaged pain. Was that, how did you come across the fact that people had unmanaged pain? Was that based on client scoring on the PEG scale? Or was
based on high scores on the PEG scale, despite being on long-term opioids. And I would sort of, it's a blunt interpretation, but I would say if people are still getting those very high scores consistently, despite being on high-dose opioids, for me, that suggests that their pain management plan has some scope for improvement, that non-medicine approaches, multimodal approaches and, pain programs, all of those things that we know work. Many of the things that work best actually have got nothing to do with medicines at all. But that's often getting patients on board with kind of the need to take broader approaches, being able to get those referrals in place for our other kind of colleagues that are helping people with pain, and being able to get into pain management services, etc. So I would, that's essentially what we're kind of flagging as unmanaged pain. And, it is very distressing for someone to be on those high pain scores and the opioids not be working.
Yeah, definitely. And somebody's just put a note in front of me just to give you a heads up that you gave a plug for Nicolette Ellis's webinar, which I would definitely second, but she's also online with... Yeah,
I can see Nicolette there. Hello.
Just checking. So yeah, just in case you wanted to pass any questions over to her, by all means pass the buck, because Nicolette has agreed to stand in.
Yeah, and dive in at any time, Nicolette. I know that you've been driving a lot of this effort, which has been fantastic.
Yeah. And thank you, Susie. It's been a fantastic presentation. And just to reiterate around the question around the comms that we're doing from Queensland Health's point of view, we are ramping those up throughout September. You will see, I know probably everyone's very sick of webinars, but in this COVID state that we're in, we do really need to sort of use our digital applications as much as we can. And we're working with all the peak bodies to help drive this, because it is not only system level peak bodies, but it's individuals that really need to drive this within, and if you are working within general practice or hospital or wherever you are, and you've got this information, it might be useful just to have a quick 10-15 minute presentation with your colleagues, let them know that this is coming. And that exactly what Susie was talking about is that it is an alert, but it doesn't tell you what to do clinically. It's really there just for your information, so we don't have incidences of harm. Hopefully we're reducing harms to patients due to these monitored medicines that do occur, but they do have a therapeutic use, and we need to use them judiciously and understand what is best for our patients. And only we can sort of understand that because we're talking with our patients. So please look out onto the QScript Learning portal as well. There's lots of webinars that are coming up that both myself and Dr. Susan Valentine will be running about how to get QScript ready, and then also dedicated to prescribers, pharmacists, dentists, and all of the good folk who get to use QScript.
Yeah, excellent. Thank you, Nick. Go on.
I can see a query there around considering referral to opioid substitution programs and when that might be considered. So I can talk to that for a minute. So what I've provided is a brief screen that might help you identify where somebody has opioid use disorder. If someone's screening positive to that, what your next step be might depend a little bit on how confident you are in kind of making a diagnosis of opioid use disorder. If that's something you're familiar with, then certainly go ahead. If that's something that you'd like to have support of addiction medicine colleagues, I did put up the phone number earlier in the slides. I would reach out to get advice around that if you're not confident doing that yourself. In terms of when you might consider opioid substitution, I think it's when we have not just a brief screening tool, but a proper assessment that identifies that somebody has sort of moderate to severe opioid use disorder. And before going down that road, often the kinds of things that you might try is putting structure in place. So we know often people who have chronic pain and opioid use disorder can actually continue to manage their pain with additional structure. So maybe not getting a month worth of opioids at a time, but having opioids, every couple of days, maybe trying to rationalize what medicines they're on to reduce the risk. But there are patients who are able to manage their pain with opioids, despite having an opioid use disorder with appropriate support. Where that's not working and that risk continues to, and the risk is too great to continue down that route, that might be when you're thinking about a referral for something like buprenorphine, which will, we know, significantly reduce the risk for that individual. And actually, because it's a very long-acting opioid, we can often get better pain control as well. So you're talking about an opioid with a really long half-life. People need to take it just once a day. It's going to give you a lot better pain coverage throughout the day than being on lots of short-acting opioids where your pain and opioid kind of levels going up and down throughout the day. And people actually do find, in general, their pain either is no worse or it improves once they're transitioned onto sort of a buprenorphine or a methadone. So that's, if somebody's not having good coverage with their opioids and they have an opioid use disorder, I would definitely be looking at those longer-acting, safer opioids as a good part of the plan.
Definitely. And just building on for that, somebody's also asked, are we getting more GPs registered to prescribe? And certainly we're doing our best, and legislation is moving in that direction and encouraging GPs to take that on board more often. And anything we can do to promote that, I think, is a good thing. I guess one of the other questions that just builds on from what you were talking about there, Susie, is you've obviously had a similar system down in Melbourne for a longer period of time. And when it came out, did AOD services, mental health services, did we see any increase in presentations as a result of, anxiety concerns, either from the prescriber or from the clients themselves that were having issues with their GPs?
Yeah. Look, anecdotally, we've heard a little bit of that. Just to cast your mind back to when our prescription monitoring went mandatory, it was on the 1st of April 2020, when things were really escalating with the COVID pandemic. So it's a little difficult, I think, to get a really clear sense of what was happening at that time because, because our AOD services, things were really difficult to manage. Everyone was in kind of pandemic response mode. So I don't think we've got a really clear picture yet in terms of the impact of that because of some of those background things that were happening. We did hear a little bit about that. We also heard, unfortunately, some people may have kind of had difficulty accessing their medicines because alerts are overinterpreted. So I think that you absolutely have the benefit of learning from what happened with the implementation in Victoria. And just to echo Nicolette's point earlier, when I was downloading some of the QScript information sheets, I think it's really clear in the messaging in the 2 pages that are there that this doesn't tell you what to do. It doesn't tell you can't supply opioids. You make the clinical decision, you're in charge. And I think that messaging is really great and it's really clear in the information. So if people are accessing that information, I think that will be positive.
Definitely. Somebody's come in with another question, which is highly valid. There's lots of webinars like this that we're talking about for professionals, for the GPs that are going to be accessing this program. Is there client-specific information being developed so that they're aware of this coming out and how it might influence their treatment in future? Is there anything client-focused that you're aware of being developed?
Nicolette's probably best placed to answer that.
So we do have a number of medication fact sheets for patients who are taking monitored medicines that are available on the QScript Learning portal, and we're also be updating our government QScript website as well for that. And Strategic Comms Branch is in charge of all consumer communications. We just finished a really great consumer research project, which looked at consumers' perceptions of QScript and what information they ideally would like to receive. So once QScript is launched, then we will have a dedicated consumer website that will be available for consumers. And lots of different information. And they really wanted to, one of the key things that came out of that consumer research was they really wanted to have this conversation with their doctors and their main prescriber. And they wanted support from their pharmacist and they wanted to understand what a high risk alert would be, and to understand what that means in context with them and how to manage the risk. So they just really wanted that open communication between their care providers, and they thought if they were taking the medication as prescribed, then and directed by their prescriber, then they were not at risk of having that reduced or abruptly ceased. So I think that's all really good learnings for us, and myself and Sue are going to use a lot of that consumer research into our training with pharmacists and prescribers to make sure that's sort of echoed through.
Perfect. Couple of easy ones. I've only got two left and they're relatively easy ones, I think. So back to Susie, the pain scale that you highlighted earlier, does that allow or include emotional pain when you're scoring, or is it purely physical pain that it looks at? And if not, are there any that you're aware of that would also incorporate emotional pain?
So the PEG has those three domains of someone's pain severity, the effect on the enjoyment of people's life, and their general functioning. I think it's quite difficult to unpack emotional pain and physical pain. Pain is subjective. We know that, in fact, when people have a lot of distress, their pain is often rated to be higher. So I think if you're asking someone about their pain and they're telling you about their pain, I don't think you would necessarily be able to unpack whether or not that's physical or subjective. And if someone says that they're in pain, and they're experiencing that as pain, that's what they're
discomfort wherever it comes from. Yeah,
but I think definitely the elements of distress around pain can often reflect that as well. I'm not sure if I've answered the question.
Yeah, no, I think that's a fair point. I think one definitely leads into another, and trying to divide them equally, clearly is not going to be an easy thing. The final question I have, like yourself, we're big proponents of promoting naloxone. You mentioned about, obviously, anyone that's over 50 milligrams OME, you'd be looking at having naloxone provision, certainly a discussion. Is this something in QScript, because obviously we want GPs to also be doing this, is this something that will be prompted, much like an alert if they're about to prescribe opioids? Is there any system where it reminds them, hey, don't forget to talk to them and provide some education around naloxone, or is it down to them just to try and remember to do that?
I think that might be something Nicolette would need to speak to.
So the way that we have designed QScript is that if you have that over 100 OME, or the combination of opioids and benzos, or even if you're thinking of someone who's currently on the QE2P program, maybe prescribed a combination monitored medicine, you can view a bit more detail about that alert function, and then it talks you through basic steps of what you could do to minimize the risk, which would include naloxone therapy in those cases. And a lot of the other suggestions that Susie had as well around, potentially stage supply, reduce quantities, for a period of time, lots of education with the patient, understand the benefits and the risks. So all of that is included within QScript, which I think is really valuable. So it's a quick guide for prescribers and pharmacists to go directly to that area and see how they could minimize risks for a patient who's triggered one of the high risk alerts.